I'm going to give you an update on GI cancer. It's a very broad area with multiple subsites, and I thought about trying to cover radiotherapy and chemotherapy, but actually the volume of data that's come out in the last 2 years made that impossible. So I've settled just on the radiotherapy side of things. So I work at UCH and treat all subsites of GI cancer. So rectum, anal canal, esophagus, and pancreas are the main ones I'm going to focus on today. There are, of course, other areas that are treated, which I will guide you towards having a little bit more of a read around on, but I haven't got time to cover all of that today, unfortunately. So I'm going to go through each tumour subsite and go through the standard practice, and then also the changes that we've made quite rapidly nationally and internationally, which we implemented across London in the last few months for COVID, and also where there's trials available, the current trials, and then potential directions in the next year or two. What I won't have time to discuss, which is a growing area, is Saber for oligometastatic disease. Particularly in COVID, it's rapidly increased as a surgery sparing technique, but any patient that you come across who has low volume metachronous disease, so disease that appears at 1 to 3 sites more than 6 months after the primary diagnosis, is likely to be eligible by NHS England criteria. And also there's an increasing use of curative treatment for HCC using Saber as an alternative to other treatments. And finally, I'm not going to dwell on chemotherapy, but there's 3 key areas of practice changing data which I've outlined here from ASCO this year and last year. The Beacon study is the first non-chemotherapy biological targeted regime for metastatic colorectal cancer. The Keynote 177 immunotherapy study looking at single agent Pembro for colorectal cancer, and the data showing 3 months versus 6 months for adjuvant chemotherapy in colorectal patients. So I'd suggest that you pull out those articles and presentations and have a look at those, because they are now being implemented in practice. So I'll start with rectal cancer. This slide applies to all tumour sites, but clearly it's integrating everyone's viewpoints in the MDT, which is absolutely crucial. And rectal cancer is one of the trickiest discussions that we have in GI cancer about the best approach, whether it's chemotherapy, radiotherapy, combination of any of those, or straight to surgery. MRI, absolutely crucial for staging, and the aim of treatment is to get clear resection margins achieved through total mesorectal excision with an R0 resection. The patients that we see in oncology are ones where that is less likely to be achieved, and we need to offer some sort of preoperative treatment. So there is a selective use of preoperative radiotherapy or chemoradiotherapy predominantly, and a small role now for neoadjuvant chemotherapy as well. And there are some circumstances where we can achieve complete response with neoadjuvant treatment alone, which is excellent as an option for potentially sparing surgery. This is the current Esmo Guidelines, which stratifies rectal cancer patients into risk groups, which hasn't particularly changed over the last 5 years. The ones that we tend to see are the higher risk patients who definitely need neoadjuvant treatment, and predominantly has been chemoradiotherapy up until COVID. And then some of the intermediate risk patients, where they have larger tumours, node positivity or EMVI positivity, do benefit from radiotherapy as well. Just a reminder, radiotherapy is best given before surgery as opposed to an adjuvant approach. There's the German study from 2004, updated 2012, showed a doubling of the rates of local recurrence with post-operative treatment being offered for R1 or R2 resections. It narrowed a little bit. This is the updated data showing there's a 3% difference in local recurrence rates. Complete response rates across the board in all rectal cancer patients with chemoradiotherapy is approximately 12 to 15%. T1, T2 tumours, you can get 50% complete response. T4 tumours, it's down to less than 10% complete response rates. We tend not to give chemoradiotherapy to T1, T2, but there are trials looking at it. So the standard approach is probably similar to strategies you've been aware of over the last 3 to 5 years. Whole pelvis radiotherapy, including the primary tumour, and uninvolved lymph nodes, 45 Gray in 25 daily fractions. And then most centres now are giving a boost to the macroscopic involved tumour, usually with 5.4 Gray 3 fractions. And this can be either given sequentially if you're using a non-IMRT approach, or as an integrated boost in 25 fractions with 2 dose levels. And the benefit of that is it obviously speeds up the treatment time, slightly better quality for the patients. So let me go back. Oops. There we go. And then chemotherapy, generally capecitabine is preferred as outpatient treatment and doesn't require any lines. An alternative is the 5FU continuous infusion regime, and the capecitabine is 825 milligrams per meter squared orally 5 days a week. Half of the studies have used continuous capecitabine, half have used 5 days a week. There doesn't seem to be a difference between those strategies, and we tend to give it 5 days a week for tolerability. Delineation, the UK Delineation Guidelines, which are within the Aristotle and Trek trial protocols, which I've put a link here for. And also there's some excellent American PowerPoint presentation slides, step by step from your CT scan to the finished plan, which I've also put the link here for. That's a slide at the bottom from the RTOG guidelines, but essentially outlines the elective lymph node areas and also how you grow the volumes step by step. I won't be going through those specific details on any of these tumour sites today. Intensification of chemotherapy with capecitabine 5FU based chemoradiotherapy. I'll whiz through this because actually there has been no benefit for all of these strategies. Oxaliplatin was offered and considered in addition to capecitabine and 5FU, increased toxicity, equivalent complete response rate, and reduced compliance with treatment. So there's no statistical significance for the addition of oxaliplatin in all of these large phase 3 studies, bar one, but a subsequent meta-analysis has shown no significant benefit in overall survival for the addition of oxaliplatin. Similarly, smaller phase 2 studies with the addition of cetuximab to chemorad these are the pathological and complete response rates down the bottom, 12%, so doesn't seem to show any benefit. Similarly with Avastin, there's no additional benefit in complete response rates. So those are not recommended. The newest concept, which is going through clinical assessment in a number of international phase 3 studies, is the approach of total neoadjuvant therapy. And this is bringing all of the treatment up front, so giving the chemotherapy up front and the radiotherapy up front, and then looking at whether you give 5 fractions of radiotherapy over 1 week, 5 by 5, or giving chemorad. The first big phase 3 study was published and presented at ASCO this year, the Rapido study, which you may possibly have come across, and it is potentially practice changing. It is only an abstract, so they're going to have to publish it, but for high risk T4 EMVI positive, heavily node positive, CRM positive patients, they were randomized between chemorad, the usual weight in surgery, with adjuvant chemotherapy, the top line, versus short course radiotherapy, which is the blue area here, 5 fractions, and then 6 or 9 cycles of Folfox or Capox before proceeding to surgery. Now, the data was very very impressive. It showed, first of all, the metastasis-free survival at 3 years in the experimental arm was 7% better, so a significant reduction in the risk of distant metastasis. path-CR rates were almost double, from 13% to 27% at surgery, and the local regional failure rate was equivalent in both arms. So this has been recommended as a standard of treatment, and I've started treating some patients with this regime. Now, COVID in rectal cancer, this slide applies to all GI tumour sites and probably all radiotherapy sites. The aim is to reduce patients' exposure to the community and reduce patients' exposure to the hospitals. Also, there is the risk of reduced resources from staff illness and longer daily treatment times from the requirement for PPE. So we implemented, alongside the national and international guidance, predominantly using shorter fractionations, so the 25 in 5 regime in place of chemoradiotherapy. And this is an excerpt from our guidelines, which is basically taken from those national guidelines. So all cases where we would have normally given chemorad to, we discussed in our weekly planning meeting and agreed that it was suitable for 5 fractions. We would also consider a boost up to 30 gray in 5 fractions to the macroscopic disease. And we've had about 5 patients come through this, and actually the response rates have been, they appear to be pretty similar to giving long course chemorad when you give 30 gray in 5 fractions. So it's actually a very good regime and very well tolerated. The final aspect is looking at radiation dose escalation from the current 50.4 in 25 fractions. At the moment, there isn't any phase 3 data showing that there is any additional benefit. In the bottom, we've got the bottom corner here, we've got the Proton dose distribution curves that you may be aware of, and clearly that's an area, particularly at UCH and Manchester, and we will be looking at in trials as to whether we can dose escalate and also minimise normal tissue toxicity. There is one UK dose escalation phase 2 study, the Aphrodite study, which is looking at dose escalating up to 62 gray in 28 fractions. These are lower risk patients who are expected to get a very good complete response rate, potentially up to 30 to 50% anyway, and this is hoping to increase that response rate. So in summary, the standard chemoradiotherapy regime is 5 to 5.5 weeks chemorad with 5-FU or CAPE. We can also consider total neoadjuvant therapy, Rapido style, or to avoid COVID risks, radiotherapy alone with or without a boost up to 30 gray to the macroscopic disease. Now, swiftly moving on to anal cancer. So this is predominantly based on the ACT-2 trial, which is over a decade old, and these are the standard treatment dose fractionations for delivering long course curative chemoradiotherapy to patients with squamous cell carcinoma of the anal canal. The lower risk patients, node negative patients, tumour doses 50.4 in 28 fractions with a lower elective lymph node dose of 40 gray. And then the higher risk patients increase the dose up to 53.2 gray. And this is all delivered using a VMAT technique in one phase with an integrated boost. Chemotherapy, again, is similar to the regimes used over the last 5 to 10 years, with mitomycin C on day 1, and then concurrent chemotherapy with the same dosing regime as per rectal cancer. Again, delineation guidelines are available. There's a national UK delineation IMRT guidance with the link here, which is freely available. And also there's a link to the Plato study, which is the next step after Act 2. This is Act 3, Act 4, and Act 5 in one study. And this trial has very similar, or the same actual delineation guidelines, but more information about rectal cancer. So it's very well worth reviewing. The COVID guidelines, we haven't particularly changed our treatment of anal cancer because most anal cancers are treated by chemoradiotherapy, and they are a priority 1 tumour on the RCR guidance. And we felt less inclined to switch their treatment to a shorter fractionation because there's much less data for it. So the vast majority have continued with chemorad through COVID. There is some data, which were in those 2 publications and at the bottom here, which showed that 30 and 10 or 30 and 15 with chemotherapy may be of benefit, particularly in older patients or poor performance patients. This is an overview of the currently running national phase 2 and phase 3 combined study, Plato. And this has 3 studies, Act 3, Act 4 and Act 5 in one umbrella study, looking at the low risk in Act 3, intermediate risk in Act 4 and high risk anal cancer patients in Act 5. The intermediate risk patients in Act 4 are being randomized 2-to-1 to a dose reduction in radiation because their cure rates are so good at the current doses. The Act 5 patients are looking at dose escalation with the dose up to 58.8 gray in 28 fractions. And Act 3 is looking at the very early low risk patients, and it's an observational study for anal margin tumours and the use of adjuvant low risk radiotherapy. So that is ongoing and available at a variety of London centres if you come across any patients, and also around Britain. Now,
I've got 5 minutes.
Oh, good. Okay. Carcinoma of the esophagus. Esmo Guidelines here. Radiotherapy has a role in all types of esophageal cancer when it's beyond T1, T2 node negative. So either definitive or preoperative chemoradiotherapy. Preoperative chemotherapy, the data is from the CROSS trial, which shows excellent resection rates if you give neoadjuvant chemoradiotherapy first. The standard chemotherapy, chemoradiotherapy approach is from the data from 20 years ago with either 50 and 25 or 50.4 and 28 with cis and 5FU or cisplatin and capecitabine. Most centres now are using cisplatin and capecitabine because you can dissolve capecitabine in warm water and drink it, so it doesn't. There's not a problem even in esophageal cancer patients. Delineation Guidelines. The national phase 3 study Scope 2 has excellent delineation guidelines. This is an excerpt from it, and there's also a webinar on the RCR website from one of the clinicians in Manchester on how to delineate. For COVID, we have hypofractionated with concurrent chemotherapy. So at the bottom here, we're offering the standard regime at present. We're offering 40 to 45 gray and 15 fractions with concurrent carboplatin and Taxol, and there is some data for that, and there's a summary on the RCR website here of the data behind that, but it reduces visits by 2 weeks and reduces their exposure to chemotherapy. And this is a summary of the Scope 2 study, which is open, which is looking at different chemotherapy regimes and the use of PET to assess which regime they should go on to, and that's for radical treatments of squamous and adenocarcinomas. And finally, moving on to the pancreas, chemoradiotherapy regimes remain unchanged over the last 5 years. Usual practice for locally advanced non-metastatic pancreatic cancer is induction chemotherapy. If you have stable or partial response, you then can consider them for chemoradiotherapy, 45 to 50.4 gray and 25 to 28 fractions. Now using VMAT, ideally with 4D CT and abdominal compression, if you have those available, and it's a category 2 tumour. But there is now a move towards actually moving from chemoradiotherapy to a 5-fraction Saber conformal treatment, and I'll move on to that data in a second. Again, there's lovely delineation guidelines in the national phase 3 study Scallop 2. This is a link to it with all the details, and that goes through a step-by-step methodology of outlining. And now this data has been was published just recently, a meta-analysis looking at the comparison between chemoradiotherapy and Saber for pancreatic cancer, and it shows very impressive results. It's not a phase 3 study, but it's a combination of different phase 2 studies, and has supported the move away from chemoradiotherapy to Saber. So the overall survival in patients who had Saber for pancreatic cancer over 1 week, 5 fractions, versus 5.5 weeks of chemoradiotherapy was improved by 13%. And there's a much lower toxicity with Saber, from 37% down to 2%. So again, in COVID, we've transferred our guidance to offer 30 fractions in 30 gray and 5 fractions for these patients. If we can't use 4DCT, we drop it to 25 in 5 fractions, and we currently aren't offering chemo-rad for these patients due to the excess risk and what appears to be a slightly higher benefit. SCALLOP-2 trial unfortunately just closed, partly because people are moving away from giving chemo-rad. So they recruited half the patients to this quite complex study, and they will present that in due course. So, summary: rectal cancer chemo-rad versus total neoadjuvant therapy versus 5 fractions. Anal cancer, consider chemoradiotherapy, but just about every single patient in Britain is eligible for Plato trial. So do consider making sure they're referred for that. Esophageal cancer, chemoradiotherapy, either pre-op or definitive. Consider hypofractionated regimes. And pancreatic cancer, chemoradiotherapy has been the standard, but increasingly moving over to the 5-fraction Saber and SBRT regime. That's it. Thank you very much.